Good morning, good afternoon, possibly good evening to some of you. My name is Catherine Kane. I work for the Health Workforce Department at the World Health Organization. I'd like to welcome you today to the final episode of our Health Workforce in COVID-19 Action Series. Today, we'll be focusing on the theme Together, which is one of the three interlocking themes of the International Year of Health and Care Workers. We have an exciting panel today to speak with you about observations of challenges, approaches, successes, and questions about how we address human resources for health and how we bring together multi-stakeholder, multi-sectoral innovation and solid practice in order to ensure that we support health and care workers. This session will be recorded, and we will be placing that recording along with relevant materials on the Health Workforce website and mailing it to all of our participants after the presentations. The format is 4 panelists, followed by a question and answer session. We hope you'll take advantage of the Q&A function in order to share your questions for this distinguished panel of guests. I am also pleased to note that we have simultaneous interpretation. If you use the button at the bottom of your screen, you will see an option to change to any of the UN languages. One of our presentations will be in Spanish, so it will help now if you choose your favorite language. I am very pleased to have Deputy Director General Susanna Jakob to kick off this session.
Dear colleagues, the interlocking themes of the International Year of Health and Care Workers are protect, invest, together. The UN General Assembly just issued a joint statement reinforcing the moral obligation to the health and care workers who have sacrificed their well-being and even their lives so we can continue ours. As we strive to make 2021 a year of transformation, we must listen, evaluate, learn, and turn lessons shared into concrete strategies, actions, and commitments. We must support the health and care workers, who are the foundation of our ambitions to end this pandemic and emerge better prepared for the next, more resilient, and more cohesive. The first 2 episodes of the Health Workforce and COVID-19 Action Series centered around protection and investment. Our final episode focuses on the links that align and strengthen our promises and actions, togetherness. Multi-sectoral, multi-stakeholder action is at the core of effective policy and management of human resources for health. Whole of society engagement is at the core of emergency preparedness, response, and recovery. The health workforce policy and management in the context of the COVID-19 pandemic response interim guidance prompts policymakers and managers to streamline decision-making processes, explore new partnerships to promote public policies, and strengthen intersectoral collaboration to mobilize the necessary pandemic response. Multi-sectoral action spans health, labor, education, and finance ministries, and often includes agencies responsible for gender, youth, water, and sanitation and social policy. In addition, COVID-19 response coordination often expanded to include defense, foreign affairs, social security, media, and telecommunications agencies across levels of government, national, subnational, local, and types of employers, public, private, not-for-profit. Today we will hear from professional associations, civil society organizations, governments, and regional alliances about a range of strategies and interventions taken to ensure the readiness, education, and protection of health and care workers. The actions and strategies include mobilizing health and care workers, providing innovative and timely education and training, representing community needs, promoting public health practices, addressing labor rights and decent working conditions, promoting adoption and tailoring of policies and protocols, and much more. Rapid, flexible, and innovative approaches rely not only on leveraging existing mechanisms for political, social, and fiscal dialogue, but also on forging new alliances and improving on existing coordination. The Access to COVID Tools Accelerator Health Systems Connector is one example. Unprecedented investment, research, and development, acceleration, and innovation in the diagnostic, treatment, and vaccines tools is needed. It must include support for learning, employment, and support for health and care workers so that they are ready to respond to the pandemic and facilitate the rollout of diagnostics, therapeutics, and vaccines. As we all know, vaccines don't deliver themselves. Within WHO, we have greater alignment and synergy than ever amongst our teams at all levels. We are working more closely than ever with funding, implementing, academic, and civil society partners. We see a great potential in the Access to COVID Tools Accelerator to foster a similar alignment among development partners, but it is especially in countries that we advocate coordinated actions by governments and partners in support of the pandemic response. This whole of society approach is essential to propel us through the COVID-19 response and rebuild and fortify health systems and their human capital, health and care workers, against future attacks on our collective health and well-being. Earlier this month, 127 member states adopted a joint statement at the United Nations General Assembly expressing support for the International Year of Health and Care Workers and calling for a global care compact to protect health and care workers. The Global Care Compact will consolidate internationally adopted and recognized principles and recommendations into a single reference document to inform national dialogue, policy, and action for the protection of health and care workers' rights, decent work, and practice environments. Episode 1 brought together global human resources experts to share insights on health and care worker protection through ensuring training and supervision, strengthening infection prevention and control, providing mental health resources, and designing decent work environments. Episode 2 convened UN partners and international financing institutions to urge and support them in designing funding support for sustainable future-looking health workforce investment that has multifold economic, social, equity, jobs, and health returns on investment. In this final episode, which is far from being our final learning opportunity, we appreciate your participation and hope that you will join us in promoting two key objectives of the International Year of Health and Care Workers: engaging governments and all relevant stakeholders in dialogue on the Global Care Compact, and bringing together communities, influencers, political and social support in solidarity, advocacy, and care for health and care workers. We can end this COVID-19 pandemic. We must end this pandemic. We must do this together.
I think that's a call to action from our Deputy Director General. I hope you will join us in answering that call to action. Now I am delighted to introduce our first panelist, Dr. Samuel Asagid, who is the Director of Human Resources for Health Development in the Ministry of Health from Ethiopia. Dr. Asagid.
Thank you so much. Good morning, good afternoon, everyone. I'm very happy to be part of this critical engagement, which is game changer, talking the health workforce issues, which is critical in our COVID emergency response throughout the world. So I am Asagid and working as Director for Human Resource for Health Development in Ethiopia. So I will try to share you briefly how Ethiopia prepares health workforce for the COVID-19 emergency. My brief presentation outline will be, I will talk a bit about the country context. I will go on some of the health workforce trends that we have faced in the past 3-4 years. I will talk about how we prepare the health workforce for this COVID-19 emergency. And I will have some words on the International Year of Health and Care Workers. And finally, I will have some message on the resolution that Ethiopia adopted with Senegal in WHO 24th Assembly. Talking about the country context, as most of you know, I can say Ethiopia is a country, one of the big countries in Africa, and the second most populous country in Africa. Nearly 150 million plus, and the majority of the population in our country are under 50, which is equivalent to 50%. So most of the population, I can say, are the young one. So we do have 1.2 million kilometer land area. We are having 10 states and 2 city administrations, as you see in the map. So talking on some of the major indicators, on the past nearly two decades, we have showed remarkable improvements in major indicators. So if we see the life expectancy, there is a trajectory increase from 61.6 years in 2010 to 65.8 years in 2018. And the infant mortality rate also declined from 7 in 2005 to 43 in 2019, and under 5 mortality rate also declined. So in most of the indicators, there are lots of increments, there are lots of changes that we have recorded in the past 2 decades. So the big issue that I would like to give focus is the health workforce. You know, the big question everybody asks is why the health workforce is important and critical. So it's known that if we talk about, you know, the health facility structure, the technology, and any other things, the contribution for any, the contribution of success for any institution is very low. So the health workforce contribution to any institution success is critical, and it took more than 60%, as some studies say. So the health workforce is critical to achieve most of the UHC commitments, the SDG commitments, and other global promises. So the health workforce is very critical in availing the essential service package. So without health workforce, it is very difficult to move and implement all our plans in the health service. So talking about the health workforce is talking about the health system. So the health workforce is very critical in every aspect of the health system, I can say. So the health workforce trained in our country is actually, if you see the number, we are having nearly 50,000 to 20,000 increments per annum. So currently we are having more than 273,000 health workforce in the country. So the past 2 decades, the number of health workforce in our country increases, more than double. But when we compare this with the global benchmark, the global standards, the country, we need to invest more in availing more number of health workforce. So the emergency response in COVID, the index case actually found in our country in 30 March 2020. So since the first case was found, the government took various measures, to mitigate the spread of the virus, starting from declaring state of emergency, schools were closed, and lots of different variety of measures were taken to mitigate, to decrease, the spread of the virus. So as of June 30, 2021, we identified nearly more than 270,000 cases, and nearly 4,320 days were recorded. So some of the vital aspects of the COVID-19 emergency response were actually the government did lots of investment in improving the quarantine centers. The government deals with, hotels, different schools, higher institutions to support in quarantine isolation support. The treatment facilities were also increased. The laboratory capacity was one of the critical challenges we were having when we found the index case. So through lots of investment negotiation, the number of laboratories were also increased. Screening and emergency operation centers were also increased. The COVID management centers, distributing different kinds of IPC materials, protocols, and different guidelines were designed. The PPAs were also, the shortage, not only here, but globally, but the government did its best to improve the availability of personal protective equipment in our health facilities. The handbooks for COVID-19 professionals, because we were having challenge for our health professionals in how they isolate themselves when they get positive, when they tested, negative, and other things were challenged during the first 2-3 months of, the emergency. So for that, we did develop the handbooks. The WHO also supported the government, to increase the capacity of health workforce. So from this, we learned that the number of health workforce for COVID-19 emergency is critical. We need to increase the number of health workers available to respond to this emergency. So with this core part of the emergency response, we duly identified that we need more number of health workforce. So how do we avail this number, having the regular service without interruption of the regular service? So what we did was actually, we have, forecast the needs, we also mapped the actual need that we need to respond to this emergency. So for this, WHO and other partners supported in forecasting the number of health workforce needed to respond for this emergency. So for this to happen, actually having the surge capacity, we duly identified the number of health workforce that should be in place to respond for this emergency. So having the adequate number, what we did was actually just provided training. As all knows, COVID is a new emergency. The health professional, the community, and everyone has did not have adequate knowledge and skills on the prevention, on the clinical management, and other aspects. So for that, we identified a virtual online platform for our health professionals, and we were able, to provide training within a week time for more than 7,000 health professionals. And with health professional associations, we cascaded lots of, face-to-face trainings, in considering the COVID-19 protocols. The other one is we already have, the evidence-based estimation was made actually with support of, the rich and other countries. Also, we just tried to make the health workforce available and, prepared and self-sufficient and safe, because in order health professionals to support others, they need to feel comfortable and sufficiently feel safe. We did that one. The other one is actually the government made lots of efforts, to mobilize, volunteers, because during the emergency, the first, 3-4 months of the emergency, we were in preparation of in preparing different volunteers to be ready to support if the case was out of control. So for that, we recruited volunteers. We also, collected data from retired health professionals, those unemployed, and we also tracked the number of health professionals under training in different higher education institutions. So with all these activities, we just tried to determine and made evidence-based estimation for the emergency response. With all these activities, we just try to make ready-made available health workforce if the emergency gets out of control. So nearly we have recruited more than 23,000 health workers deployed in different healthcare facilities, in quarantine, in isolation centers, and nearly 25% of them are specialists and general practitioners. In this COVID emergency response, what we did also was actually we just tried, to design different kinds of motivation and incentive package to motivate the health workforce. So we designed a different package, and the government gave approval for that one. So the life and health insurance scheme and special allowance were designed for health professionals who, who are deployed in emergency response. The extra funding were also mobilized to high-load hospitals, because most of the hospitals were expected, to deliver the regular service, and they were also expected, to provide service for COVID cases. So for those hospitals who have high load, the government provided extra funding. Guidelines and protocols for isolation were also provided, and the quarantine and treatment for healthcare workers were also dedicated. So the government designed a dedicated quarantine and treatment centers for healthcare workers. So more than 1,750 quarantine treatment residency beds were designed, specifically for our healthcare workers. These were the main deliverables that the government did to make available, to make conducive for our healthcare workers to fight against this emergency. So these were actually the main tasks we did in the emergency response. The other one, as WHO declares 2021 as the year of health and care workers. Here in the picture, as you see, our minister, the state minister, the WHO country officer representative, on their presence, we have launched the national year, cascading the international year to our context, and we have launched the international year of the health and care workers. So the government already determined to celebrate a national year recognition for healthcare workers after a week. The other one, having all the commitments of the International Year of Healthcare Workers, actually Ethiopia and Senegal actually tabled a resolution to WHO 74th Assembly, And we were lucky that we have adopted a resolution on protecting, safeguarding, and investing healthcare workforce. So I think this is also one of the inspiring things, and one of the great commitments that the Ethiopian government did to show its support and its admiration to our healthcare workers. So this resolution is critical, not only our country, but also for all countries in the world. For the main highlights included in this resolution was actually providing equitable access to vaccines, therapeutics, and diagnostics for all healthcare workers in COVID-19 response and other future outbreaks is very important, because most of the time COVID teaches us a lot in how to support our healthcare workers. So it's not only during COVID or during emergency times, but our healthcare workers need to be supported whether there's emergency or not. The other one is the support decent work, education, recognition, and reward is very critical. So pay equitably, and the rights, responsibilities, and duties of the health professionals need to be respected. So there needs to be also prevention of harassment against healthcare workers. Some evidence so this kind of practice are observed in some situations. The other one is this is time to coordinate the national workforce investment agenda and action plan. These were the main highlights stipulated in this resolution. So finally, this is the time currently to highly protect our healthcare workers. It's beyond a moral obligation that we need to protect our healthcare workers, that they sacrifice themselves for us. So this is the time to strengthen this activity in the upcoming years. Investment is very critical. We need to mobilize all government donors, bilateral and multilateral donors need to mobilize resources to invest in our healthcare workers. And finally, we need to do things together. There needs to be a multi-sectoral engagement to improve the indirect investment, attain sustainable and UHC goals. So if we do together all these things, I think the future will be good for our healthcare workers. Thank you so much for your attention. I'm done.
Dr. Asagid, thank you for closing with "There is no health without the health workforce," and for highlighting such important elements of the International Year of Health and Care Workers, as well as the Ethiopia commitment at the political and investment level to increase the number of health workers based on labor market conditions and population needs. I'm going to turn next to Dr. Rosbel Toledo Ortiz, a surgeon and occupational health specialist, who is the coordinator of education and training of health personnel in the National Medical Coordination of INSABI in Mexico. Dr. Toledo.
Thank you very much. Yo soy quien va a dar la exposición en español. Agradezco a los traductores. Procuraré darla de una manera breve y clara. Agradezco a mi secretario de Salud, el doctor Jorge Alcocer Varela, por la oportunidad de presentar esta información que tiene México en relación a su fuerza de trabajo ocupacional del personal de salud en México y cómo nos preparamos para la atención de la pandemia a nivel sectorial. Quisiera empezar explicando un poco cómo funciona el sistema de salud mexicano. Prácticamente está dividido en dos sectores grandes. La primera mitad es la atención a las personas sin seguridad social, las que tienen un trabajo informal o no cuentan con la posibilidad de contar con protección de la seguridad social. Y la otra mitad atendida precisamente por instituciones de seguridad social, como el Instituto Mexicano del Seguro Social, la Seguridad Social de los Trabajadores del Estado y las Secretarías de Defensa Nacional y de Marina. En el lado de la atención a las personas sin seguridad social se encuentra nuestro Instituto de Salud para el Bienestar y un segmento específico del IMSS que conocemos como IMSS Bienestar. Si nos damos cuenta en este gráfico, pues prácticamente los diferentes estados de nuestro país cuentan con esta distribución de protección de la seguridad social de forma diferencial. En las áreas o estados más urbanizados se cuenta con mayor seguridad social y en los menos urbanizados con menor protección por trabajos informales. Entonces hablamos de un sector salud de alguna manera fragmentado, separado, y esto era un reto ante la pandemia. Para la atención de la pandemia por COVID-19, había que hacer algo precisamente para atender a toda la población de una manera más uniforme y todos juntos. Como resumen, en nuestro país tiene 190,565 médicos, a 286,000 personal de enfermería y contamos con 1,395 hospitales en todo el sector. Particularmente sobre la atención a COVID, como ustedes saben, el 31 de diciembre se presentó el brote en Wuhan, China, y nosotros tuvimos tiempo para prepararnos. Hubo toda una fase de preparación para hasta el 11 de marzo declarar una pandemia a nivel nacional. En enero iniciamos la fase de preparación, desarrollamos la prueba confirmatoria en una de nuestras instituciones y se generó un Comité Nacional para la Seguridad en Salud, que es sectorial. Todas las instituciones de salud que conforman nuestro sector salud, nuestra Secretaría de Salud, se unieron precisamente para planificar la respuesta. Y abordamos estas tres fases, la de importación por viajes, la de dispersión comunitaria y la fase epidémica que nuestro país inició el 11 de marzo, con acciones específicas en cada una de estas fases. ¿Qué hicimos entonces? Buscamos reducir la velocidad de transmisión y mitigación de la epidemia, asegurar la atención de los casos graves, prevenir desde el nivel comunitario, atender de manera integral a la población, atender la coepidemia de salud mental, tener reuniones importantes de inteligencia para la toma de decisiones de manera sectorial y garantizar la atención médica de calidad, así como vigilar el comportamiento de la epidemia. Nos enfocamos principalmente en la población y en la sociedad, no precisamente en el individuo, sino en el análisis poblacional. Y entonces practicamos estas fases de anticipación y preparación, de una detección temprana con la realización de pruebas de PCR y posteriormente pruebas rápidas, las medidas de salud pública y la fase de mitigación y control. Para lo cual obviamente necesitábamos de una fuerza de trabajo o personal de salud altamente capacitado. Para fines prácticos, para la atención de cualquier emergencia, es importante incrementar la capacidad de respuesta en tres aspectos. Y esto sí es en inglés: staff, structure. En cuanto a staff, pues hablamos de el incremento en el reclutamiento del personal. Necesitábamos más personal para atender a mayor cantidad de población, la conformación y reorganización del personal ya existente en equipos de respuesta COVID, que así le llamamos. Asimismo, incrementar en los que ya estaban su capacidad de atención, sus conocimientos para atender una nueva enfermedad no conocida. Y también importante la protección de los trabajadores de la salud. Lo que hicimos en un primer momento fue proteger a nuestros trabajadores con mayor riesgos o vulnerabilidades. Nosotros contábamos con un antecedente muy importante de la epidemia de influenza en 2009. Juntamos a nuestros mejores epidemiólogos del país e identificamos que los factores de riesgo ponían en riesgo, aumentaban la probabilidad de infección grave o la muerte por factores de riesgo individuales, por lo que decidimos proteger a nuestros trabajadores con mayores vulnerabilidades y enviarlos a casa como un resguardo domiciliario o trabajo en casa en caso de que fuera posible. Y asimismo gestionamos la adquisición de equipo de protección personal. Sufrimos las mismas barreras que sufrieron los países en la obtención del equipo de protección, dado que en otros países presentaron esta primera oleada epidémica en los primeros momentos. En un inicio tuvimos algunos problemas para obtención del equipo, sin embargo, los grandes esfuerzos garantizaron posteriormente la protección de todo nuestro personal de salud. En cuanto a staff, pues obviamente hablamos de incremento en la distribución de insumos, medicamentos, monitores, ventiladores, con una gran inversión por parte de nuestro gobierno para fortalecer nuestros hospitales en todo el país e insistir en el equipo de protección personal y garantizarlo a todo nuestro personal de salud. Y en cuanto a estructura, pues hicimos acciones de reconversión hospitalaria, es decir, destinamos las camas de atención a otros padecimientos exclusivamente para la atención de la pandemia, construimos nuevas unidades con este gran ejemplo que dio en su momento China con la creación de este hospital en 10 días, generamos todo un modelo de 38 camas y algunos otros que se desarrollaron de forma muy rápida en muy pocas semanas. Abrimos también hospitales por indicaciones de nuestro presidente. Hospitales que estaban pendientes de terminar su construcción se abrieron de forma anticipada para la atención de la pandemia y hicimos también expansión en unidades que no eran hospitalarias para la atención de padecimientos leves. También rentamos hospitales y tuvimos un convenio con hospitales privados, con una asociación y un consorcio que explicaré más adelante, además de estrategias de atención domiciliaria para permitir la atención de pacientes más graves en nuestras camas hospitalarias. Entonces se generó un convenio marco, se firmó con todas las instituciones del sector para trabajar como una sola institución o un solo sector salud, atendiendo personas sin seguridad social en la seguridad social y personas con seguridad social en instituciones que atendían normalmente personas sin seguridad social. Este fue un gran esfuerzo por nuestro gobierno que favoreció mucho la atención de todos los pacientes en el país. Reclutamos entonces, por el liderazgo de nuestra secretaría, con acciones sectoriales, se redistribuyó el personal, se reorganizó nuestro Instituto de Salud para el Bienestar, como líder de este proceso de reclutamiento para otras instituciones, se canalizaron recursos para la contención de la pandemia a 29 de nuestros 32 estados, contratando cerca de 20,000 plazas nuevas de personal de salud y de personal paramédico también, con una inversión importante. También para el segmento de la seguridad social de los trabajadores del Estado, obtuvimos cerca de 4,200 plazas y también hicimos convenios con nuestra Secretaría de la Defensa y Marina del país, obteniendo en conjunto entre las instituciones de seguridad social y sin seguridad social hasta un reclutamiento de cerca de 61,000 personas, particularmente 12,000 médicos y una gran cantidad de enfermeras. Nuestros equipos de respuesta COVID, entonces, para la atención de 24 camas, se distribuyeron por un médico líder más especializado, 3 médicos de soporte y el resto de personal de enfermería que dieron soporte y apoyo. Adicionalmente, dimos bonos o compensaciones monetarias a nuestro personal de salud como una compensación al riesgo de infectocontagiosidad. ¿Y qué hicimos además en materia de solidaridad? El país reaccionó de forma muy solidaria. Nuestros diferentes estados se comportaron diferente en los diferentes momentos de la epidemia. En algunos había una poca contagiosidad y entonces teníamos personal de salud más disponible y en algunos lugares teníamos mayor saturación hospitalaria, por lo que se generaron brigadas sanitarias de voluntarios donde el personal que estaba más desocupado viajó a los estados para atender donde estaba más concentrada la epidemia en estos momentos. Es así como nuestras brigadas sanitarias tuvimos personal voluntario de estos estados y también se generó una estrategia que se llamó Operación Chapultepec, donde tuvimos también más de 1,000 voluntarios que viajaron hacia este Valle de México, que es la zona más urbanizada de nuestro país. También tuvimos reconocimiento por parte de nuestro gobierno, una condecoración que es la más alta presea que entrega el Estado mexicano a acciones heroicas, entregando esta cantidad de premios a nuestro personal de salud, como pueden ver en la imagen, y también haciendo un reconocimiento póstumo a los personajes y personal de salud que perdió la vida en esta epidemia. De alguna forma, para incrementar también la capacidad de respuesta del personal, teníamos que capacitarlos y formarlos en los algoritmos interinos o tratamientos internacionales reconocidos y basados en evidencia, y desarrollamos plataformas educativas donde incluimos a más de 51,000 personas con más de 286 sesiones y más de 143,000 accesos. Se generaron en el sector varias estrategias y varias plataformas. También tuvimos cerca de 300,000 capacitaciones de forma presencial en la seguridad social y cerca de 170,000 capacitaciones en línea en otras plataformas. También cursos muy específicos para el manejo de la epidemia, hasta 135,000 reproducciones de estos cursos que incrementaron la capacidad de nuestro personal de salud para la respuesta y formándolos particularmente en una serie de protocolos y de estrategias sectoriales e integradas para la respuesta a la epidemia. Se desarrollaron varios estudios de investigación, este es uno de ellos, donde se analizó la infección y muerte por COVID-19 de una cohorte de pacientes trabajadores de la salud en nuestro país, donde para fines prácticos se separaron 3 grupos. Los equipos de respuesta COVID, que atendían directamente a los pacientes con COVID, los trabajadores de la salud activos que no atendían pacientes con COVID y el personal trabajador que se encontró resguardado en casa o con trabajo domiciliario. Para fines prácticos sí se encontró una mayor tasa de infección en los trabajadores que se encontraban en contacto directo con los pacientes con COVID y nos llamó la atención que se encontró una mayor infección en otras categorías no médicas como enfermería, camillería, inhaloterapeutas. En este convenio de trabajadores o de la asociación privada, esto nos ayudó a incrementar nuestra capacidad de respuesta en infraestructura. En un primer inicio nos atendían padecimientos no COVID y posteriormente también se sumaron a la atención de la respuesta COVID, por lo que llamar a este sector privado en nuestro país fue fundamental, fue muy importante para apoyarnos en la atención de estos otros padecimientos que no podíamos dejar de atender también. Y finalmente, hablando de la protección de nuestro personal de salud en materia de vacunación, priorizamos la vacunación en 11 categorías de salud, como fueron médicos, enfermeras, laboratoristas, asistentes médicas, trabajadoras sociales, manejadores de alimentos, de higiene, ambulancia, radiólogos, camilleros e inhaloterapeutas, teniendo hasta este momento más de 1 millón de dosis aplicadas, y cuadros completos seguramente en esta misma cantidad, habiendo registrado 1.356.000 trabajadores de la salud para ser vacunadas en esta primera etapa donde en realidad los primeros que debíamos de vacunar era nuestro personal de salud. Con esto termino. Muchísimas gracias.
Dr. Toledo, thank you so much for that intervention that highlighted some important investment in augmenting the number of health and care workers and ensuring that they were well trained, including by innovative delivery by online courses, as well as the guidance that you produced. I was particularly drawn to one of your diagrams, which reminded me of a diagram of health and care workers that we actually had drawn from Corvus Health earlier this year, last year when we were writing the Human Resources for Health guidance in COVID-19. We were able to draw that diagram from a health workforce expert, Dr. Kate Tolenko, who is a physician and founder and CEO of Corvus Health, a global health workforce firm that aims to give all people access to skilled health workers. Dr. Tolenko has very graciously also accepted yesterday afternoon to step in after a death in the family prevented Dr. Sheila Tawa from the African Union Commission from joining us. Dr. Tolenko, we very much look forward to your presentation.
Thank you so much. It's a pleasure to be here. So I'm going to talk about moving health workers forward together with a multi-stakeholder, multi-sectoral engagement. Next slide. So first I want to define what multi-sector and multi-stakeholder mean. So by multi-stakeholder, we mean that at every level of the health sector, from local to national, regional, and global, you have different players, different stakeholders, such as health professional associations, patient groups, governments, the private sector, private hospitals and clinics, NGOs, and civil society. And you must involve all of these, because it's not just so much what you do, but how you do it and who you do it with. And by bringing everyone together, you're much more likely to have sustainable action. And this, in the year of the care and health worker, is a critical year to get things done for health workers, because people are so acutely aware of the importance of health workers, not just to health, but to economies, travel, to everything. And go back one slide, apologies. So for multi-sector, the health sector is significantly affected by sectors outside of health, such as ministries of labor or civil service, ministries of education, ministries of women and youth, ministries of finance. You must involve all these three. It cannot remain just in the health sector. It's very much in that way like the AIDS response, that we had to involve all sectors to have a complete response. Next slide. So I've seen, as a health worker, a specialist, I've seen 4 huge sea changes in the last year with COVID, and we'll address each of them and how we can move forward on each of them at this critical moment. The first is labor relations. The second is a large-scale exit of health workers from the health sector and from low and middle income countries. The third is the shutting down of health professional schools and the explosion of e-learning. And the fourth is the explosion of telemedicine. Next slide. So labor relations matter. So what we saw really throughout the COVID epidemic, but certainly in the beginning, was poor treatment of health workers, really reported in most countries. Health workers not being allowed to wear masks because, well, there's not an epidemic here. Masks literally being ripped off the face of health workers, or health workers not being allowed to bring their own masks because they weren't regulation masks. So they had to enter rooms completely unprotected. And also, many health systems and hospital management did not engage health professional associations or unions. So individual health workers who expressed concerns were seen as outliers, or seen as crazy people. It's important to engage these professional associations so you can get the combined voice and the combined weight of health workers. And also, there was a real and perceived lack of compassion towards health workers. Hospital leaders giving themselves huge bonuses at the same time they furlough other health workers, or cut their pay, or fire them completely. And we've seen strikes, an incredible increase in strikes. All the health workers listening now know that the last thing a health worker wants to do is strike. We want to care for our patients, and we have sworn a sacred oath to protect our patients and take care of our patients. So health workers do not want to strike. So the fact that we're seeing this blossoming of strikes shows you just how bad it is and how worn out health workers are. So you're seeing this low morale, low engagement, and that affects performance and affects patient outcomes. Next slide. So how can we move together and respond together to address these very legitimate concerns of health workers? Well, we need a whole slew of ministries to help us. Ministries of labor, women and family affairs, occupational health regulators, ministries of health, ministries of youth. And we need to get rid of this is what you signed up for dialogue, and focus on problem solving and shared sacrifice. I love what the Ministry of Health in Ethiopia did, actually providing life insurance and health insurance for health workers. So what an incredible concept. I mean, it's really just fantastic that you were able to do that for your health workers. We're seeing a lot of forced overtime that needs to be addressed. It's bad for patients. It's bad for health professionals and their family. As we know, the vast majority of health professionals, particularly nurses who get the majority of forced overtime, are women and have children and family responsibilities. We also are seeing increasing unsafe provider to patient ratios. I'm a little ambivalent about laws and regulations on provider to patient ratios, but I do think that if health systems continue to push it and have too many dangerous situations, we will see more laws, mandating provider to patient ratios. It's just not safe, and there's ample evidence for each patient you add to a nurse, the mortality rate of all of her patients increases. We're also seeing declining pay of health workers, wages eaten away by inflation, and that many health workers can make more money working in other sectors, whether it's marketing or the restaurant business or advertising, and then they won't have to work weekends, evenings, and holidays. They won't have to work in a sector where occupational risk from overuse fatigue, from violence, from infectious disease, from slip and falls is so high. So we really have to make the health sector more appealing for workers. We're also seeing an increasing debt burden of health workers, which is driving people out of the industry. Most countries have made it clear that they cannot expand health worker production with public funding alone. They're going to need private funding and private investment, and that's going to be accompanied with an increased debt burden of health workers and drive them into metropolitan areas and drive them into subspecialty work and away from primary care and rural and remote work. And we're also seeing low pay in public versus private health sector, and that needs to be remediated as well. Next slide. So we're also with COVID seeing a large scale exit of health workers. Of course, the most tragic exit is the 17,000 health workers that Amnesty International estimates have died from COVID. And then we're seeing many health workers take this opportunity to retire. They're just saying, I've had enough, I can't do this anymore, retiring, many more planned retirements. We're also seeing an acute and growing shortage of health workers in high income countries and low income countries. We know that by 2030, there will be an 18 million shortage of health workers globally, and that's going to get worse with the aging of health income of high income countries, because it's a double whammy. They'll have a larger need for health and care workers with the aging of the population. At the same time, they have fewer people at that bottom of the population pyramid who are of working age to train and work as health workers. And most countries also lost a year of production of health workers because nursing schools, medical schools, pharmacy schools were suspended either because they couldn't continue or because the students were assisting in the COVID effort. Next slide. So the solution here together really is to scale up health professional schools globally. The Chinese have a wonderful proverb that the best time to plant a tree was 20 years ago. The second best time is today. Folks, we need to plant some trees. We need to start scaling up health professional schools to meet the needs now and to meet the needs 20 years, 40 years into the future. We need to create ways for retired workers to help train and mentor the next generation so we're not losing all these highly skilled workers completely from the sector. We need to make funds available for the founding and expansion of health professional schools. Also expand funding for students to pay their fees, such as Afya Elimu, which is a rotating fund in Kenya that was set up by the Kenyan government and USAID, and Arutify, which is a startup, a financing startup that's working in the Philippines and in Indonesia to give short-term loans to students in college, including health professional students. We need to transform the regulation of health professional schools from policing and from shutting down schools to supporting and bringing all schools up and helping them expand. And we need to create global public goods to decrease training costs and help run training programs. This is part of an initiative that I'm part of, a 500 health professional schools initiative, which is working on this to create these global public goods and to help schools expand. Next slide. And so the third phenomenon that I see and that we have a unique chance to work on to help move health workers forward was the shutting down of health professional schools and this explosion of e-learning. It was not just for health workers, it was for all types of students. An important thing to note is these learning losses were higher in low and middle income countries than in less resource schools in wealthy countries than in wealthy countries in general, or in the better resource schools in wealthy countries. So this is an increase in that digital divide. Wealthy countries didn't miss a beat. They just kept on with their classes. I work with a group of private health professional schools in Uganda. Most of them still have not reopened a year and a half later. So this is a desperate loss of training capacity. But the positive side is most professional skills added e-learning. Pre-service education is known to be a very sort of rigid, stodgy industry, and this advanced the profession, advanced the schools probably by 10 or 20 years, just in a single year of e-learning. The students that we have now in their 20s and 30s, they're digital natives. They want to do e-learning in addition to the face-to-face and mentoring. Most students report wanting to keep elements of e-learning. So even as they go back to face-to-face classrooms, they want to keep the supplementary e-learning that they found help them learn faster, better, do more problem solving. And we also need to work together to help identify these gaps in clinical skills and how we can improve e-learning and clinical skills, that laying of hands, you know, the simulation mannequins and other ways to help people improve clinical skills when they can't be in health facilities. Next slide. So working together on this, you know, once again, it's going to be all hands on desk with ministries, you know, telecom providers, ministries of telecommunication, ministries of financing and education. We need to prioritize that bridging of the digital divide. The internet is now a utility. You would not expect or not want a health worker to work without water, electricity. They cannot work also without internet. So we need to prioritize internet access for students and health workers. And we need to remember there's no additional cost per additional learner for most e-learning. And so these are purely global public goods. And I do want to mention the WHO Academy, which is creating those global public goods, you know, free courses, high quality courses available to anyone. Next Gen University, which is putting a full nursing school curriculum online, which nursing schools can use. Somali Ren, which is providing internet access to schools and colleges in Somalia, and then the 500 Health Professional Schools Initiative that I mentioned before. And so we need to work, as I mentioned, with telecom providers and others. Next slide. So the last point is the explosion of telemedicine. The Journal of the American Medical Association has estimated that telemedicine services in the US increased by 1,000% in March 2020 and 4,000% in 2022. So you see health workers, thousands of health workers who'd never done telemedicine before, now doing telemedicine. Tens of thousands of patients who'd never done telemedicine before, now receiving telemedicine and liking it. You know, because telemedicine benefits both health workers and patients during crises, whether that's a pandemic, a severe weather event, a war, whatever it is. If it's unsafe to leave your home, telemedicine really is very helpful for that. Telemedicine also is extremely good for patient satisfaction, especially if you're triaging and helping a family decide whether they need to go to the emergency room or not, or you have a remote patient who you're doing chronic disease management and you're adjusting their diabetes medications. You can save them hours by doing that as a telemedicine visit. Next slide. So once again, you know, we all need to work together, ministries of health, commerce, telecommunications, telecoms, you know, to advance telemedicine and realize its promise and avoid its pitfalls. Telemedicine can lead to physician shopping, and it can lead to too many requests for antibiotic seeking. So we must be aware of that. But telemedicine has the opportunity to bridge this health worker maldistribution and get healthcare to rural and remote populations. It's important to note that most health workers lack a telemedicine regulatory framework. I have to say most countries in which I've worked, that is the case. And just to give you an example from the US and US states, in some states, physicians can prescribe antibiotics via telemedicine, in others they can't. In some states, they can prescribe oral contraceptives via telemedicine. In some states, they can prescribe controlled medicines such as opioids via telemedicine. In some, they can't. It's also not clear in many countries, well, what profession can provide telemedicine? You know, is it just physicians? Is it nurse practitioners? Is it nurses? Is it pharmacists? And what is their scope of practice within that telemedicine? We also need to train current health workers in telemedicine because as someone who's actually provided telemedicine, it's not the same. You have a very different way of interacting with the patient, a very different way of doing the physical exam. So we need to integrate that into pre-service education as well as in-service training and CPD. And so with that, I want to thank you And I look forward to your questions after the last speaker.
Dr. Telenko, thank you so much for that thought-provoking discussion, bringing together labor relations, keeping health workers in the sector, telemedicine, and the need to educate, train, and catch up on what we've lost in education over the past year. It was really good to hear you highlighting the WHO Academy, and I hope you've tried the PPE course. It was a great refresher for me, and certainly shows how far we've come in innovation. Our final speaker, our final speaker for the day is Mr. Howard Catton, who is here representing the World Health Professions Alliance, which is currently chaired by the International Council of Nurses, of which Mr. Catton is Chief Executive Officer. I think you will find him thought-provoking and interesting as well. Mr.
Catherine, thank you so much for the invitation. Colleagues, it's great to be able to join you, and thank you to the previous speakers who I think have given some wonderful and insightful, thought-provoking presentations. I don't have a presentation, but I do just want to give you a few thoughts and reflections which will draw on some of the things which previous colleagues have highlighted, but also I think some thoughts and some pointers from all of the World Health Professional Associations about where we need to go from here. For those of you who don't know about ICN, the International Council of Nurses is the confederation that speaks on behalf of nursing. We're more than 130 national nursing associations strong in the region of 27 million nurses worldwide. We work together through the World Health Professions Alliance with our colleagues from the World Medical Association, World Pharmacists, Dentists and Therapists Associations. We think probably pushing 45 million healthcare professionals worldwide. First observation, which I think that we should always just remind ourselves of, is how short the world went into this pandemic of healthcare professionals. We know that we were at least 6 million nurses short at the start of the pandemic, and something like 18 million short of health care workers generally. Those numbers often don't feel as though they mean anything and they don't resonate. So I just say to you, imagine that you're a healthcare worker and your team is 20%, 25% short already. And then you are asked to face the biggest ever challenge that your team has had to face. And that doesn't last a week or a month or a year, but 15 or 16 months, and it's still ongoing. When we talk about lack of preparedness, the shortages and the lack of investment in the healthcare workforce is emblematic of the world's lack of preparedness. And that, I think, that's the first observation for me, which I wouldn't want us to lose from this discussion. Dr. Kate has highlighted many of the issues that we know have impacted on the healthcare workforce. The International Council of Nurses, the other healthcare professionals, have run a commentary on issues like infections amongst healthcare workers, at some stages up to 10%, numbers of deaths amongst healthcare workers, the mental health and psychological impact. We've described that as the traumatization of the healthcare workforce because it's complex and it varied. It's not just about anxiety and burnout. Some of it is said very complicated in terms of issues to do dealing with violence, discrimination, COVID deniers, abuse when you're coming off shifts as well. We are already seeing evidence of nurses and other healthcare workers quitting and leaving. They've simply had enough. Dr. Kate highlighted strikes, absolutely, but also disputes as well around the world. We've called this the COVID effect on the healthcare workforce. And my second observation is that I still don't think we truly know or understand what the scale and the impact of that COVID effect is. We've done some work from nursing to say that actually we think the nursing shortage is more now like 12 or 13 million, not 6 million. Similarly, I think all of the data that we're looking at in terms of shortage predates the pandemic and will have been exacerbated and will be worse as a result of that. So we now hear people talking about the importance of recovery and rebuilding of our healthcare systems. And whilst a number of colleagues do, not all do, put the health workforce at the centre of that rebuild. Our health systems are people, it's people what matter. And right now, I think all of us should be making sure that those recovery and rebuild plans have the healthcare workforce right at the very centre. But where are those plans, colleagues? Do you know where yours is for your country? Who's working on it? What it looks like? I thought Dr. Samuel and Dr. Rosbell's presentations excellent in terms of the plans that clearly exist for their countries. But I'm not sure that I consistently see those in countries around the world. Talk is cheap. Countries need plans, and they also need plans which are supported by funding. Historically, in many countries, we've seen a boom and bust approach to funding of health services. It's a major contributor, I believe, to the lack of preparedness that I mentioned right at the front end. What are countries doing now to secure funding, to increase funding, to look at share of GDP, how much they currently spend and how much they need to support their plan for recovery and rebuilding of their health systems? I don't mean to sound trite, but a plan and a funded plan feel to me fundamental building blocks that we need to see much more of. From a nursing and midwifery perspective, in terms of having a global plan, we have one that was agreed just at the WHO with colleagues from WHO. We have a new nursing and midwifery strategy, and I'm not going to go into all of the details of that, but it has a very simple strapline. Invest now in education, in leadership, and in decent jobs. So if people don't have a plan, but they're not sure what will go in it, the healthcare professionals can easily tell you what needs to go in it and will be delighted to work on a plan. I wanted to reflect a little bit on the scale of deaths that we've seen as a result of COVID. We've been tracking through ICN, and the other professions have as well, but we know that at the World Health Assembly, Dr. Tedros said that at least 115,000 healthcare workers have died as a result of contracting coronavirus. I think it's likeliest to be more than that, though that is a shocking figure. That's 200 plus healthcare workers a day who have died since the start of the pandemic. A reflection on that, though. If this would have happened in any other sector, can you imagine an aeroplane with 200 people going down? How many days before there was an urgent investigations, a search for answers, flights were stopped, people looking for the black box recorders? Who's looking for the black box recorders on healthcare worker deaths now? And those numbers will continue to rise. And one of the reasons why they'll continue to rise is because we have still the gross inequalities in relation to access to vaccines. And a lot has been said and a lot has been written about that. But let me just try and personalize that a little bit more. How would you feel being a nurse, doctor, healthcare worker, porter, cleaner, support worker, being asked to go to work today in an area where COVID patients are being cared for without a vaccine? How would that make you feel? How would that make your family feel? There's huge moral questions about the impact of our inability to more equitably deliver vaccines, which I think we need to ask ourselves some very searching questions on, of course, but I think it's also a key issue that takes us back to the shortage issue. What will the impact on future recruitment into the healthcare workforce, as well as the retention of current health workers be, as a result of their experiences and the feeling that they are not being protected, their human rights are not being respected. There's an issue with PPE, just as another example, that around the world we know that there are issues with access to PPE and faulty and fake PPE, but we also know that health workers consistently since the outbreak have been calling for access to FFP3 masks, higher grade masks and not surgical masks, arguing for a precautionary principle to protect them. And that hasn't happened. That access hasn't been happening around the world in a systematic way. Yet, just in the last few weeks, there has been some interim findings from what I think will be a hugely significant study that shows that the use of FFP3 masks almost eliminates the risks of transmission of the virus to our healthcare workers. I think, colleagues, we're at this point where healthcare workers, they see the statues, the memorials, the badges, the flag days, and enough. We need to see a plan. We need to see funding, and those, I think, are some of the harder questions that we now need to be asking of countries right the way around the world. Catherine, I just wanted to finish up just making a couple of other comments, if I may, switching slightly, but in relation to this issue of together. I do not think that we talk enough about the importance and value of national nursing associations for groups of healthcare professionals and groups of healthcare workers. Kate mentioned them, and I just want to unpick it a little bit more in terms of what some of their functions are. They have been the organisations who've been at the forefront of advocacy and representing healthcare workers right the way around the world. They are the people who I think have been bringing the reality of what's happening at the front line to the attention of policymakers, politicians, the public, in a way that others have not. But they have also been the people who have been leading innovations to practice and to care as well. And through those associations, they're often the people who are speaking truth to power, because their only interest is to represent the people who are their members. They're a little bit outside of the system. But they're also the organisations who I have seen providing many services to frontline staff. I have seen associations right the way around developing helplines for people with mental health issues, providing mentoring support, providing access to education, leadership development as well. They are providing valuable and important services, and they are straddling both across all of the employment issues, but the professional practice issues as well, which I think gives them a huge, valuable, insightful voice and perspective in relation to health systems safety. You know about the Nursing Now campaign. It's been one of its great successes is that it's brought together all of the different component parts of nursing, researchers, educators, associations, nurse managers, nurse leaders. I think there is a challenge for the professions to do much more to bring themselves together in a unified voice, both as professions, but also on a multi-professional basis. And I've mentioned that that I'm talking on behalf of the World Health Professions Alliance as well. The add value that those multidisciplinary coalitions bring is that they can help us piece together the fault lines across our health systems, where the cracks, where the misalignments are, where the duplication exists as well. I'm not sure that we are using I'm not sure we're recognizing the value of associations sufficiently, and then using them and frankly to exploit their expertise, their reach deep into our health systems and our healthcare professionals, and bearing in mind as well that these are the organizations who are representing some of the most trusted people that we have. And we know now that the issues around vaccines, trust and the credibility of the public health messages are just key. So Catherine, my final reflection on this is that I think there is a discussion for us about new mechanisms for social dialogue. That all sounds very grand and textbook, doesn't it? Or perhaps it doesn't. It's things that people have talked about before. But what mechanisms really are in place within organizations for the voices from the front line to be heard, but not just to be heard, to be acted on, to be seen, to make a difference, to be part of not just safety, but the continual improvement, the quality improvement of our healthcare organizations. If we are not talking together, we are not working together. And I think that there's something more that we can do in that spirit of togetherness to build more effective, inclusive, meaningful structures and mechanisms for all voices who are involved in delivering healthcare to be heard and to influence back to the recovery and the rebuild that we need. Catherine, back to you.
Mr. Catton, you rarely cease to come up with something new and provocative. I particularly, as somebody who used to respond to transportation disasters, your idea of the black box is quite right. We search for the black box from the moment one. We need to do that for health and care workers. I appreciate also that you mentioned vaccine equity. Without repeating anything that our honored panelists have said, I'm going to do one quick question to each of you. I do ask that you keep your responses to 2 minutes so that we respect all of the participants' time, and we will circulate additional questions. But your interjections, your interventions have been absolutely magnificent. I'll start with Dr. Asagid. The question that we've received from the audience is, how did you mobilize resources? You added a number of health workers in Ethiopia. How did you ensure you could pay them and pay the costs of bringing them on board?
Thank you so much, Mr. Moderator, for the question. This is a very critical question. One of the issues we faced were mobilizing resources for the health professionals recruitment. So for this, what we did was actually the government, was committed to recruit professionals in a temporary basis. For that one, we just hired greater than 10,000 professionals in a temporary basis. And we also negotiated with partners to support us in paying salaries for the health professionals. And some of the partners were willing to do so. So these are the things that we did. But the big challenge was actually some of the professionals were recruited in a temporary basis. So we are now planning to change this type of contract to permanent basis. In this, the Ethiopian physically starting as of tomorrow. So the government, is trying to mobilize some resources to the health sector. That's what we did to increase the health financing to our healthcare workers. Thank you.
Thank you. A quick question to Dr. Toledo Ortiz. How in Mexico did you address the issue of harassment of health workers during the pandemic? Dr. Ortiz, I think you're muted.
Yes, can you hear me? Well, I'm going to say in Spanish. Efectivamente, tuvimos una fuerte campaña de acoso contra el personal de salud, de atentados incluso al personal de enfermería, a los médicos que atendían pacientes con COVID. tuvimos varias campañas de concientización para la población general sobre la importancia de la actuación del personal de salud, sobre su seguridad y sobre la gratitud que debíamos tener como pueblo con nuestro personal de salud. Recuerdo mucho una presentación de la maestra Fabiana, la jefa Fabiana, de una representante de enfermería a nivel nacional de nuestro sector, donde precisamente se hacía un llamado al evitar el acoso para el personal de salud. Y prácticamente fueron varias campañas que se realizaron en diferentes estados y por eso surgió de hecho el reconocimiento de la condecoración Miguel Hidalgo, para hacerle saber a la gente que los actos que estaban haciendo nuestro personal de salud son actos heroicos, arriesgando precisamente su vida, su integridad, entregando su capacidad por la población, haciendo un llamado enfático a la población para evitar el riesgo de contagio, buscando que se quedaran en casa y evitando la contagiosidad comunitaria, digamos, y reconociendo en todo momento el valor, el heroísmo, pues, de nuestro personal de salud. Entonces fue a través de campañas como se buscó limitar el acoso en nuestro personal.
Muchísimas gracias. For Dr. Tolenko, what about gaps in clinical skills training? How would you address that?
Yes, and apologies, my camera has stopped working for some reason. So there are two answers to that. The long-term answer is all health worker students really need to start seeing patients from week one, whether they're pharmacists, nurses, physicians, because it's such a core essential, as I said, that laying of hands. So I would start that. I think it's wrong for someone to do medical school for 5 years and then, see their first patient. But for the people who've lost a year, we're probably going to have to organize special boot camps where they can, work with the patient volunteers or work with simulated patients or the mannequins. But also, I think that there's some policy work that needs to be done to improve access to patients. I mean, the great irony in many low-income countries where you have the greatest burden of disease is you have the worst access of health worker students to patients. You'll see 10 medical students around a single patient. And so we were actually just supporting Somalia to help them with their regulation of health workers. And proposed policy that we have put in is every health facility of a certain size, public or private, will need to take health worker students. And if they do not want to, because they're a prestigious private institution and their patients don't want to see students, they will pay a certain amount into a health worker student scholarship fund. So we really must increase that access of health worker students to patients.
Thank you for that, Dr. Tolenko. Mr. Catton, I'm going to give a question to you. You addressed vaccine equity, and in fact, this morning we had Professor Sheila Tlo, of the former Minister of Health of Botswana, and she has not been vaccinated because she is and her country is prioritizing other risk categories. How would you address and prepare the health workforce for vaccines rollout?
Wow. Look, I think that there are at least there are two huge issues here. The first one is to do with the lack of supply and then the distribution chain as well. I hear a lot of the discussions that are taking place, and this happened around the G7 about the issue of vaccine hesitancy. And I'm not underplaying how important that's an important issue. But to keep with the controversial view on this, it felt a bit like the magician's trick. Look at vaccine hesitancy over here, where the real issue is that we do not have enough. We have enough supply. And again, it's an example of where, whilst we heard of commitments, welcome as they are, to 1 billion or 2 billion doses, where is the plan to share those around the world? And then I think there is this really difficult discussion about when you then say or you hear politicians who will say, national politicians, my primary duty is to look after, to protect the people who elected me in my country. Well, when you work internationally, that doesn't work for me, because that means as a consequence of that, there'll be people who get infected and who'll die within other countries, which is why I think that you've seen people like ICN, you've seen the other World Medical Associations raising these issues at UN level, at a G7 level as well. It feels to me as though we really need that multilateral and political leadership like we have never done before, and I think that we should be pushing and we should be driving that. Just on a very practical issue though, Catherine, let's never forget that the success of these rollout programs is down to people on the ground. If we've got them but we haven't got people to get the jabs into arms, it ain't gonna happen, which is another reason why the protect, the invest, and all the other issues that we've talked about are just so fundamental.
Thank you, Mr. Catton. And I know WHPA recently had a discussion led by the FIP, the Pharmacists Association, on how private and public pharmacists can work together to support the rollout. So there are some other discussions, and I'm going to just go really quickly to my colleague, Dr. Giorgio Cometto, to talk a little bit, very briefly, about the health workforce and vaccines rollout. I think you could refer to both guidance and Act A work.
Yeah, thank you, Catherine, and thanks to all the panelists as well as the participants for really insightful questions. Indeed, this has been at the heart of our work, but not just as Health Workforce Department in WHO, but really part of the broader community that we support and that we're part of, advocating for the inclusion of relevant workforce elements in the context of the COVID-19 response. Last year, this was much primarily about the clinical response capacity, and we have produced guidance and we have worked hard to support its implementation in terms of assessing the health workforce surge requirements for the response. When vaccines became available, we have similarly produced estimates of the additional workers that will be required to support a successful rollout of the vaccination campaign. And the numbers, of course, are enormous. It's hundreds of thousands of additional full-time equivalents of health workers required, even for the modest targets that were set last year of some 20% immunization coverage, which we know is not ambitious enough. We have to do better than that. But as an intermediate target, that was what guided the planning assumptions. So we have to work hard to build those estimates, the understanding of these requirements into national development plans, national investment plans. And speaking to the dimension of partnership and bringing partners together, I think there is no better example than the ACTA, the Access to COVID Tools Accelerator that has been put in place primarily to promote the rollout of medicines and preventive commodities and now diagnostics and vaccines. But as Howard pointed out, all of these commodities need people to deliver them. So it's equally important that as these plans are rolled out and funded, that the health workforce component is part of that. So I would encourage all of you in your respective capacities to take part in these conversations at the national level. We have heard in today's session some excellent examples from Ethiopia and Mexico, where the human element was really brought center stage into the planning, but we need this to be applied consistently as an approach if we are to be successful in the vaccination campaign. Thank you, and back to you, Catherine.
And to that, I would just add one beautiful piece of guidance that is the result of collaboration between UNICEF, WHO, and the Community Health Impact Coalition, outlining the community health worker role in supporting vaccines rollout. Lastly, I would like to thank all of you for your contributions to such an important discussion and dialogue. We talked about political commitment. We talked about the need for practice regulation. We've talked extensively about the need for investment, and most importantly, the need for us to come together on this. This is investment in the health and care workforce is not something that's accomplished only by member states or private institutions. We all invest, we all contribute, we all work together. I ask you to join us in two objectives of the International Year of Health and Care Workers. One of these objectives, engage member states and all relevant stakeholders in a dialogue on a care compact to protect health and care workers' rights, decent work, and practice environments. The second, bring together communities, influencers, political and social support in solidarity, advocacy, and care for health and care workers. We can do this together. It requires us all to be in dialogue with each other. We look forward to bringing you the next episode. This is the final episode in this series. We believe that we will be having an episode soon in which we can introduce to you the Global Health and Care Compact. We appreciate the inputs of our IT colleagues, of our valued interpreters, of the action team composed of Ms. Beatrice Wamutitu, Mrs. Sharad Agarwal, Dr. Giorgio Cometto, and our Health Workforce Director, Dr. Jim Campbell. And most importantly, we appreciate the interventions from each of our panelists, Dr. Tolenko, Mr. Catton, Dr. Asagid, and Dr. Rosbel Otis. Thank you so much for sharing with us. We are not finished learning. We are not finished working together. It is the year to protect, invest together.